cold in there. Howdy y'all, it's Dr. Jeff Jarvis and I want to talk y'all through our hyperthermia and heat stroke protocol. And I also want to talk to you about a new procedure that we're adding to this protocol. Specifically, we're going to roll out cold water immersion with this protocol revision.
Good morning, friends.
So I want to start with the takeaways. Bottom line right up front, most people with mild to moderate hyperthermia, we also refer to them as heat cramps or even heat exhaustion. Most of them can be cared for with simple steps. Most importantly, get them out of the heat. Even moving them from direct sunlight into shade can make a big difference. Move them into an air-conditioned environment if possible, and thankfully we happen to have one of those with us most of the time. Get them out of tightly fitting clothes. If they got a tie, for the love of God, get a tie off of them. Give them some water or other cool fluids to drink. This really goes a long way to helping cool them off. Now, if you think they're dehydrated and need an IV, by all means give them an IV. You'll notice in the protocol that there's nothing in there about starting an IV or giving oxygen or doing other things. Please don't think this means that you're not allowed to do it. I just have a personal preference against protocols that are unnecessarily cluttered and that repeat things over and over and over, particularly obvious things.
Welcome back, Captain Obvious. Yes, I am.
So that's just my philosophy about how I think protocols ought to look. What we're doing is we're trying to remove redundant supportive care items like IV fluids from across all of the protocols and put them up front into general care protocols. We'll have, say, a general protocol that authorizes you to start an IV. Give IV fluids if you think they need IV fluids. Same thing with oxygen or pain medication or nausea medication. I really don't think we have to repeat those general care steps in every single protocol. It just irritates me because it looks cluttered. Now, when we're assessing patients with heat-related emergencies, we need to do our usual and customary assessment, but we need to pay particular attention to a couple of specific points. First, we need to think about why they're hyperthermic. Elevated temperatures can come from infection or inflammation, and when that's the source, we typically refer to that as being febrile, as opposed to if it's heat stroke, we typically call that hyperthermic. So elevated temperatures can also come from exogenous or outside sources, things like the environment, exertion, or drugs like sympathomimetics, maybe a little methamphetamine or cocaine, or even anticholinergics, typically, say, Benadryl. We should also think about toxicologic reasons for hyperthermia, things like serotonin syndrome or neuroleptic malignant syndrome. We see those in drug overdoses or in interaction between different psychoactive drugs, particularly antidepressants or antipsychotics. And finally, think about hyperthyroidism or thyroid storm. That can cause elevated temperature. Now, head injuries can also interfere with our body's ability to self-regulate, so we need to consider trauma in our differential. And finally, one of the most important symptoms of heat stroke is altered mental status. So we got to pay close attention to how well our patients are mentating. We do have to keep in mind, though, that patients can be hot and confused, and the temperature is not causing the confusion. Just as an example, someone who with hypoglycemia or who is drunk in August in Fort Worth. Always check a blood glucose on a patient who is confused, even if they're hot. Now, for those patients with exertional heat stroke, the classic example here is an athlete. They can end up drinking too much water. They're worried about getting dehydrated. They're worried about getting heat stroke. They want to prevent it, so they just start drinking a lot of water. This can cause exercise-associated hyponatremia. Hyponatremia means low salt levels. And this happens if their sodium level drops too far, too fast. We ought to think about this in an athlete who develops confusion or seizures, but doesn't necessarily have grossly elevated body temperature. Management of these folks is pretty complex, and it's not the topic of this video, but if you're worried about hyponatremia, give us a call on OLPG for advice, because there may be some things that we carry that we can make use of to treat these things. Also, we should consider heat stroke even if it isn't as ridiculously hot as it is right now. So I'm recording this on a day where the high on my watch says 109 freaking degrees. Again, for like, I don't know, the 14th day in a row. It doesn't have to be this ridiculously hot to cause heat stroke. The heat index, as y'all know, that's the combination of temperature and humidity. That can also cause more damage than we might initially suspect, particularly in more vulnerable patients. Those are ones like the really young, the really old, or those who are taking medications, things like diuretics that can make them pee more and be more prone to dehydration, or maybe beta blockers, because that can blunt their normal compensatory response to something, say, tachycardia, trying to compensate for relative hypovolemia. So let's talk about how to differentiate these typical heat emergencies. So we typically think about these as a continuum from heat cramps to heat exhaustion, all the way up to heat stroke. So heat cramps, mild, usually doesn't involve anything that's an actual emergency, certainly not elevated temperature. It involves cramps. We usually, and I stress usually here because, well, we know what kind of calls come in from 911 these days, but usually we don't get called for this at all. If we do get called, what we really need to do is just get them out of the sun, give them something to drink, maybe massage their cramps, have them massage them, get a family member to massage them. Now, heat exhaustion is something that probably most of us have experienced. That's when the patient gets a headache, they get nauseous, maybe they even throw up. They get some fatigue, they might even get a little orthostatic hypotension where they stand up and they get lightheaded, or they may even pass out and have a syncopal event. So a word on syncope, remember, if they don't have a normal level of consciousness by the time you get there, it ain't syncope. Syncope, by definition, is transient. That means they pass out as they have a positional change, they go to ground, their level of consciousness returns. So for patients with heat exhaustion, you need to treat them by pretty much the same way we do heat cramps. Get them out of the environment, get them cooled down, get the ties off of them, get them some fluids, hopefully orally, if not, give them IV fluids. Now, heat stroke is the dangerous thing we're worried about here. This can be immediately life-threatening, and we can make a big difference in these patients' outcomes by rapidly cooling them. Heat stroke can be identified by grossly elevated body temperature and altered mental status, and the "and" is the important part there. Our indication for cold water immersion is a temperature above 104 and altered mental status, and we think the altered mental status is from the hyperthermia. In other words, we've already determined it isn't sepsis. It's not something else. It's not inflammation. Now, the altered mental status we're talking about here doesn't have to be a GCS of 3, although if they have a GCS of 3 and they're hyperthermic, that's really bad. Get them cooled off. Even a GCS of 14, so mild confusion, that's an indication if they got a temp of 106 that we need to get that temperature down, and we needed to get it down quickly. Now, there is a myth that I want to address about heat stroke. I was taught this beginning with my ECA class and unfortunately all the way through medical school, and that is heat stroke patients are going to be dry, they're not going to be sweating. And that's just not true. It comes from the concept that heat stroke is a failure of our thermoregulatory system. That part is true. And if you leave them alone eventually long enough, they'll get dry. But by the time we see them, they have probably been sweating profusely while their system was working. We get there, they can still very much be wet. So please don't rely on that. All right, so how are we going to know what their temperature is? Well, obviously, we take temperatures all the time. We take them orally, we take them axially, or we may do them tympanically. Now, unfortunately, those temperatures, they're just not accurate enough at the temperatures we're talking about here. And that means rectal temperatures. Now we're getting disposable rectal temperatures for just this purpose. If your patient happens to be so agitated because of their altered mental status, because of their temperature, but you just feel them radiating heat and the story goes along with it, go ahead and cool them even without that temperature. But once you get control of them, if you need to sedate them, and you can get the rectal temp, go ahead and get it. Now, patients with heat stroke, they are baking their brain and they're in imminent danger of suffering permanent neurologic dysfunction or death. We got to intervene to lower that temperature and lower it as quickly as we can. That begins first and foremost with getting them out of the sun, get them into the shade, preferably get them into an air-conditioned ambulance. Get them off hot surfaces. One thing to remember is at the temperatures we're experiencing these days, if they're on metal or concrete or asphalt, they can literally be getting third-degree burns from being in contact with that. Now, for best outcomes, these hyperthermic patients, they need to have their temps dropped in less than 30 minutes from the time they go down. Now, after 30 minutes, they start to bake their brain and their organs, and the odds of death start to go up. We got to get them cooled off fast. So we got to be aggressive about this treatment. And the best way to do that is to put them in cold water. So our cold water immersion procedure is going to lay out how to do this. I just wanted to cover the whys in this video. So there is a balance between rapid transport and rapid treatment. So I want to address something that we commonly hear and we commonly think about ourselves. And that is that short transport times mean we don't have to begin treatment in the field. They'll take care of it in the hospital. Particularly, we think that if the treatment we need to do involves something yucky that we don't really want to do, like rectal temperatures. Nobody enjoys that, but we really need an accurate temperature on these. So let's just run through a very optimistic, and I stress very optimistic scenario about what time to treatment looks like, even with short transport times. And I'm saying this in a hyperthermia video, but remember it's going to apply to other things like, say, pain management. All right, so let's say we get on scene within 10 minutes of our patient's onset of symptoms. Their temperature starts to go up because their regulation fails. We got a 10-minute scene time, probably not all that bad, and only a 5-minute drive to the hospital, but that puts us in the parking lot. We got to add 5 minutes to get them unloaded, get them into an ER, and another 5 minutes to get them registered, get the doc in the room, and order the immersion therapy. Now, we really don't have large amounts of ice in our ERs. I'm an ER doctor. I practice here at JPS and All Saints and Harris. We have ice in the ER. It's in the little machine that you put ice in your little styrofoam cup to water down your coffee, God only knows why you do that, or cool down your water. That is not exactly a high output ice maker. Now let's add these times up, all right? We had 10 minutes, and then 10 minutes, and then 5 minutes, 5 minutes, another 5 minutes. That's 35 minutes. And if you're wondering what that sound was when I said 35 minutes, that's the sound of a brain baking and organs crying out as they die. That's just too long, and that is a really, really short transport time, and it's being very optimistic about what we were able to do in the ER. Most of our transport times are longer than that, and getting ice in an ER almost certainly is going to take longer than 5 minutes. Let's take a look now, though, at what these numbers would look like for us to start treating these patients. 10 minutes down, 10-minute scene time, but that 10-minute scene time includes us getting their clothes off, putting pads on, getting them in a body bag. I'm sorry, not a body bag, an immersion containment environment. Immersion containment environment. Yes, that's right. I called it an ice bag. Thank you very much, Dr. Miller, for your really cool acronyms.
Remember, everyone, cool first, transport second. Stay frosty, my friends.
An ice bag. Why an ice bag? Why not a body bag? Turns out patients, bystanders, might be filming us, probably not going to appreciate calling out for a body bag if the patient's not actually, dead. So ice bags. We can have ice on our patient in the ice bag and begin to rapidly cool them within 20 minutes. That's 15 minutes faster than if we had just raced to the hospital because we have short transport times. We get this treatment started faster when we do it in the field. We can save patients by doing this really pretty simple thing. Now there is some, I'm a literature nerd, there is some literature on what the best treatment for heat stroke is, and it's pretty much this. They call for dropping the temperature about 1/4 degree per minute. In cold water immersion, it's the fastest way for us to do this, and it's much faster than, say, cool mist or ice packs or air conditioning. Now, for whatever reason, we don't have a fancy ice bag, grab a mega mover. Even the stretcher cover can do the job in a pinch. Now, after determining our patients have a temp above 104 and altered mental status, put the multifunction pads on them and then put them in the body bag. And the reason for that order is if you try to put the MFP pads on after getting them in the water, they're not going to stick very well. Now, we're going to put ice on MedStar supervisor vehicles, and we're working with our FRO partners to put it on various fire response units. But if you don't have ready access to ice, I want you to improvise. I am always amazed at how well y'all come up with ingenious solutions to problems. Maybe you grab it from a QT. We're actually talking to the QTs about how we can pay for it. Just go get it from a QT. If you need to, just put water on them to begin with. Maybe if it's even from a fire hose, that's all right, do that. Get them wet, then get en route in the body bag, the ice bag, and then grab the ice on the way or rendezvous with a supervisor. Y'all are smart, y'all are incredibly ingenious. I believe y'all can improvise on this. I want you to know it's okay to do that. Our goal here is what's in the best interest of the patient. Dropping that temp rapidly is the objective. Get them cooled down fast. Now we're going to go over the details of what this procedure looks like in a different video, but I wanted to go over the protocol and the disease. Our goal in the process is to get their temperature down below 102 degrees, and with ice bags, ice baths, this typically occurs very quickly, maybe within 5 minutes. If they start to shiver and they're still above 102, leave them in the bag because that's dropping the temperature rapidly. But we got to interrupt the shivering because that's generating more heat than we're dissipating. So just give them a little bit of whiff, maybe a little 2.5 of Versed to help put down that shivering. All right, so that's what to do. There are a couple of things that I want to say not to do. Don't assume that an ischemic or hemorrhagic stroke is a heat stroke just because they're hot. That would just be poor form. Also, speaking of poor form, don't overlook hypoglycemia or other reasons that they might be altered. And don't put a trauma patient or a septic patient in an ice bath. We need to treat them differently. Trauma patients need to coagulate their leaky, bleeding blood, and cold temperatures interfere with coagulopathy. We don't want to do that. So, in summary, the words that you always love to hear when I'm talking, most heat emergencies aren't actually emergencies. Heat cramps, heat exhaustion, get them out of the sun, give them something to drink. That usually takes care of most things. Heat stroke, that is grossly elevated temperature with altered mental status from that elevated temperature. If it is something that is not an infection, and the longer it's elevated, the more damage is done, and the fastest way to drop the temp is get them in cold water. Remember, not all patients with altered mental status and elevated temperature have a heat stroke. Most are going to have fever and sepsis. Treat that the way you normally would. It's also bad, but we don't really need the ice bath for them. Finally, remember that even in Texas in August, most patients with altered mental status, they're altered because of something else. Don't forget to check a blood glucose. When we bring in an altered patient in an ice bath who turns out to have a blood glucose of 20, it's not good for the patient, and let's face it, that's pretty embarrassing. All right, guys, that is the protocol review module for hyperthermia and heat stroke. Stay tuned for a fun video where I get to dunk some unsuspecting person in an ice bag. Thanks a lot, y'all. Please try to stay cool and take care.
Howdy, y'all. I'm Dr. Andrew Partain.
And I'm Dr. Emily Welch. We're ER doctors and also your EMS fellows this year with OMD.
So this is going to be the protocol demonstration for cold water immersion.
So here you're going to see our fire crew come up on a patient who has clear altered mental status and is outside on a hot day here in Fort Worth.
They're going to start their initial evaluation, including a full set of vital signs, a glucose, and a core temperature. In this case, for this diagnosis, we want to make sure that we are getting a rectal temperature on these patients. We also want to make sure that there is no other obvious trauma or other causes of altered mental status, such as sepsis, that would lead to this hyperthermia. But in this case, this is for environmental exposure leading to severe hyperthermia, also known as heat stroke, and this patient needs cold water immersion.
So here you'll see our fire crew starting to set up to actively cool the patient. The first thing they're going to do is take the patient out of the heated environment. Now, these guys don't yet have an ambulance available, so they're going to move to the next best thing, which is the shade. Then they're going to start actively cooling the patient with water. Now here, our volunteer did not have all of his clothes cut off, but in real life, you want your water, your wet sheets, anything that you're using to cool the patient as close to touching the patient's skin as possible. That means that the clothes are going to come off. You're also going to want to make sure that you put the pads and the SpO2 monitor on the patient before you start wetting them down. If you get them wet first, you're going to have a hard time sticking those pads on.
This next part here is very important. Where you get the water does not necessarily matter, whether it be from the fire engine, a fire hydrant, whether it be cutting open saline bags from your truck. Honestly, anything cooler than the patient will help cool the patient.
Shirt. All right, guys, let's move this stuff here. Go ahead.
So here you're going to see the fire crew start wetting the patient down. Again, in real life, you're probably going to want to take the clothes off the patient, but for demonstration purposes, we left them on.
Big deep breath.
In a second, you'll see our MedStar crew arrive, and they're going to start using the ice bag. Now, ICE is an acronym for the Immersion Cooling Emergency Bag, like Dr. Jarvis referenced in our other video. Please don't call it a body bag when you're in public. You can imagine that wouldn't be popular.
MedStar's out here. MedStar's on.
Now here's our MedStar crew arriving. They're going to have the ice bag with them. The fire crew is going to give them reports saying that this is a hyperthermic patient that needs cold water immersion. So you'll see them set up the ice bag on top of the stretcher, and then they're going to get some ice from their supervisor. So what you're going to want to do is set up the ice bag before you put the patient on the stretcher. Get your ice and your water however you're able. Calling your supervisor is an option, or going to any local place that's available, like a gas station, a restaurant, any of those things that you can do to get ice. You're going to want to put a little bit of the water and the ice in the bag before you put the patient in. And then you put the patient in and dump the rest of the water and ice that you have on top of the patient. You're going to want the patient about 1 or 2 inches submerged in the water at least. And once the patient is in, you'll see them zip the bag all the way up to the mid-chest. Now, again, it's important to make sure that you have pads on the patient, and you can leave an arm out to help with the SpO2 monitoring, or if you have an IV, you can leave that arm out of the bag.
So Dr. Welch, how are we going to monitor this patient? Well, good news is these pads can get wet. Now, obviously this is not ideal, but we've talked about just how important this protocol is for the patients that are experiencing this severe hyperthermia. So you can leave one arm out, continue to monitor pulse ox on that arm that you've chosen to leave out, and you can leave the defibrillation pads on the patient as well as the ECG stickers as well. Say you don't have this ice bag, well, hopefully you've got a mega mover that you can use as well. You can get that mega mover full of water and ice as well, and you can hold the sides up like a patient taco. Just make sure that your airway is maintained. You can see in this video, they've got him up to about 30 degrees. As they continue to dump ice on him, you can see the patient is really enjoying this in this video, starting to wake up just a little bit. And this is a good sign for the patient.
Some other things to consider while you're doing this protocol: you don't want to delay your cold water immersion for placing an IV. IV fluids aren't actually cold enough to cool the patient rapidly, and they don't go in very fast. So it helps a lot more with the dehydration and hypotension. If your patient is hypotensive, they do need fluids, but that's not going to be the thing that fixes their temperature. So immersion is your fastest method of cooling, and it's your number one priority in a hyperthermic patient with altered mental status.
And now it's not uncommon that your patients, as they cool, may start to shiver. And we don't want this for them because this is an attempt for their body to rewarm. So in this case, it's in the protocol that you can give your patient midazolam 2.5 milligrams as needed for shivering.
But Andrew, what if our patient codes while they're in a bag?
This is very important. You can keep them in the ice bag. Now, it may be slippery, and this is not ideal for CPR, but this is the underlying problem, is their hyperthermia. And honestly, there's a good chance you won't get ROSC unless you fix the underlying problem. Everything else is per the cardiac arrest protocol.
And I know what you're thinking. My patient's in a pool of water. How can I possibly defibrillate them if they go into VTAC or VFib? Now, we did some research on this, and the answer seems to be that you can safely defibrillate someone if they're in a bag of ice. There's been a couple of case studies in the emergency department where people have been successfully defibrillated without causing any harm to anybody else involved from VTAC. So you can do this, just be careful.
And so when can we take them out of the ice? Well, we can recheck a rectal temperature in 10 minutes, if not already at the emergency department. You can take them out of the ice once their temp is less than 102, or if their altered mentation has improved. But in all reality, we'll probably be keeping them in this until the emergency department, simply for the fact that they're in a bag of ice in the back of the ambulance.
And that's the basics of our cold water immersion protocol.
Well, Dr. Welch, this has been a lot of fun. Can't wait to do this again next time.